user. My name is Mary Villas. I am the president of PSC Partners Canada, and together with Ricky Safer, CEO and founder of PSC Partners Seeking a Cure, we welcome you to this webinar in the post-conference educational series, 3 Perspectives on PSC Care, a Fireside Chat. A very warm welcome to everybody and a sincere thank you to our moderator, Dr. Dan Pratt, and to the panelists, Dr. Black, Dr. Hirschfield, and Dr. Levy. Next slide, please. This webinar and the remaining educational series, part of the 2022 annual conference programming, have been made possible with the generous support from our sponsors, to the many community sponsors shown here who have been steadfast in supporting the work of PSC Partners. Thank you. And I should say this is the last of our 2022 conference series. Next slide, please. Thank you also to the 2022 annual conference corporate sponsors shown here: Gilead, Client, High Tide, Mirum, Escient, Perspectum, Chemomab, Children's Hospital Colorado, the Resnick Family Center for PSC Research at Brigham Health, and the Transplant Center at Mass General Brigham. This project is supported by the Chan Zuckerberg Initiative. Next slide. And over to you, Ricky.
Thank you, Mary. Hello, everybody. Thank you for joining us tonight for what we expect to be an educational and lively session and a new format for us. Instead of our usual beginning with slide presentations from our 3 expert speakers, this will be a casual fireside chat. It's a chance for you to ask burning questions that you have as a patient or caregiver. We've chosen our 3 speakers for their individual perspectives: Dr. Gideon Hirschfield from Canada, Dr. Cynthia Levy from the US, and Dr. Dennis Black, also from the US, who will give us the pediatric perspective. The questions tonight come from 2 different sources. Some are questions that were submitted by our community members during last year's webinars but have not yet been answered. And then there are the questions that you will submit into the Q&A tonight. Dr. Dan Pratt, our moderator, will cover as many topics as possible. We rely on all of you to suggest timely topics of interest to you. First, here are a few reminders of some of our upcoming events you might be interested in. But please join us on March 20th for our next webinar from 6 to 7 p.m. Mountain Time. It's our second webinar in our Embracing Diversity in PSC webinar series, FDA Insights on the Role of Health Equity in Developing Treatments for Rare Diseases. We are excited to hear from 2 excellent speakers from the FDA, Dr. Richard A. Arojo and Dr. Sandra Retsky. Next slide, please. And now it is my pleasure to introduce tonight's moderator, Dr. Dan Pratt. Dr. Pratt is Assistant Professor of Medicine at Harvard Medical School and Director of the Autoimmune and Cholestatic Liver Center at Mass General Hospital. Dr. Pratt's particular area of clinical interest is autoimmune and cholestatic liver disease, including PSC. Dr. Pratt is the head of the PSC registry at Mass General. And now I'll turn it over to you, Dr. Pratt. Thank you.
Thank you, Ricky, and good evening, everyone. I am absolutely delighted to have been asked to moderate tonight's event and to have the opportunity to have a conversation with 3 distinguished PSC colleagues. In addition to doing important research, they are all accomplished and compassionate physicians. And let me introduce them to you. First off, and representing the pediatric perspective, is Dr. Dennis Black. Dr. Black is a pediatric hepatologist, professor of pediatrics, and professor of physiology at the University of Tennessee Health Science Center in Memphis. Additionally, he is vice president for research for Le Bonheur Children's Medical Center. His research and clinical interests are in pediatric liver disease and transplantation. Our second panelist is Dr. Gideon Hirschfield. Dr. Hirschfield holds the Lilly and Terry Horner Chair in Autoimmune Liver Disease at the University of Toronto, where he is a professor of medicine. He oversees numerous translational and trials-based clinical projects with the goal of advancing therapies for patients with inflammatory liver disease, including PSC. And last, but certainly not least, is Dr. Cynthia Levy. Dr. Levy is is the Associate Director of the Schiff Center for Liver Diseases at the University of Miami, where she is a professor of medicine. She holds the Arthur Hertz Endowed Chair in Liver Diseases. Dr. Levy's research focuses on clinical trial development and conduct for autoimmune and cholestatic liver diseases, including PSC. My goal for this evening as the moderator is to make this as conversational and personal as this format allows. And I know that if anyone can manage it, it will be this panel. As mentioned, Joanne and Ricky have provided a number of questions PSC patients, caregivers, and parents have submitted. I have placed those questions into broad categories and tweaked them a bit with the goal of generating conversation. Time will not allow us to get through all the questions, but I promise we will get through as many as we can. And so with that in mind, I'd love to get this started. I see that everyone is on their camera. And so what I wanted to do is to begin with a discussion regarding our current understanding of the causes of PSC. And I'm interested to hear from each of you that, broadly speaking, when do you discuss our current understanding of PSC, the causes of PSC, with your patients and their families? And how does that all work in your clinical practice? And Gideon, do you want to jump in with the first one?
Great question to start off with. So the cause of PSC in 30 seconds. So
we'll give you as much as you want, Gideon.
It is a great question because, of course, from a patient perspective, one of the things that's most frustrating is being given a diagnosis but not having an explanation about why you've got what you've got. And then how can you expect to sort of cope with that uncertainty when, the physician in front of you can't really explain it? So the way I explain it as the cause of the disease is this is a chronic inflammatory, autoinflammatory, your body attacking yourself, disease of your bile ducts and usually your colon. So I see it as a mucosal immune disease where the colon and the bile ducts are, very, very similar, and your body is, chronically attacking those. And the response to the inflammation is scarring and stenosis. And why that inflammation arises is really, the way I always think about it, is a combination of three things. Something around your genes, and particularly around your HLA, so your immune response to a certain category or certain collection of different environmental triggers. We call them antigens. I think that's the first thing. The second thing is then something within your environment, be that from your microbiome out to what you inhale, or the substances that you're exposed to. And then the third thing, I'm afraid, is a little bit of bad luck. And then when the bad luck comes along, the environment and the immune system meet, and you've got chronic inflammation. And for whatever reason, you don't have the ability to turn that off, either because the trigger remains there, or because, in fact, the disease is a consequence of the failure to actually heal properly and go back to the beginning. And I'm afraid that, to me, then explains why you then get chronic inflammation, scarring, and all the secondary consequences. So, I think, that's my broad understanding of why people get PSC. And then, but I look forward to hearing, from the others. You've got, different perspectives, and particularly when you think about pediatric patients who may have done no environmental triggers in a sense. And, and with Cynthia working in a very diverse part of the world where patients come from all over the world, but still get the same appearances. So, there's some flaws in my argument.
Dennis, would you like to comment?
Well, I really like Gideon's approach, and I probably hit on some of those points in talking to parents, and also patients, older patients, teenagers. They're involved in the discussion as well. I find it usually by the time a patient gets to me, they've gone to Dr. Google, and some of it, fairly valid, other just kind of, way off the chart. But I think the key thing is really, keeping it as simple as possible. And, you can't really get off in the weeds, talking about 4 or 5 different theories of, how the pathogenesis of PSC. But, and then the other thing is a lot of them before their child became ill with PSC, really, if they had heard of PSC, really thought of it as an adult disease that didn't affect children. So they're really surprised and sometimes even shocked that their child has PSC. So I try to reassure them that, yeah, there are a number of children with PSC and they are under good care at a number of centers around the country. Ongoing research is making slow progress, but hopefully we'll get there with a treatment. Again, I think the paradigm of you're born with your genes, you have a genetic background that maybe predisposes you to have your immune system get out of whack and then triggered through interactions with the environment. And then you get this disease where your body's immune system attacks your bile ducts, and in many cases also they'll have inflammatory bowel disease. So I try to, and then when I'm talking, of course, the question always leads to what's the prognosis and what treatments are available. And particularly in pediatrics, I try to be realistic, but also upbeat and encouraging and hopeful when I discuss that with the patients as well. And, I go through, yeah, these are the facts of complications and so forth, and very limited treatments and no cure, but there are a lot of efforts going on around the world, to try to get to that. So I guess I'm a little more maybe optimistic, upbeat with my pediatric patients. But anyway, okay. I'll stop there.
Optimism is good. What do you think, Cynthia? Anything you want to add? Oh, you are muted, Cynthia. So.
Well, good evening, everybody. Well, first of all, thank you for the invitation. It's really nice to be here and to have the opportunity to connect. Well, Gideon and Dennis covered a lot, and that is the basis of what we know about the etiology and pathogenesis of PSC. I would add a couple of just remarks. So there is a component of heritability, and a lot of patients then immediately ask me, but then what's the chance that my child is going to have it, right? So I reassure patients that yes, it's described, and we have clusters, we have parents where you have the parent and the child, or siblings with PSC, but that's rare, even though this is a heritable disease, right? So it's rare that we're going to have these families. It happens, but they shouldn't worry about that because it's very, very uncommon. So I like to reassure in that aspect. And then about the pathogenesis, we highlight the immune nature of the disease and therefore the association with other autoimmune conditions. Also, I like to bring that up. IBD is one of them, the most common, the most striking and hallmark of the disease, but there are other autoimmune diseases that we can see in association with PSC as well. So I bring that into the discussion. And this, so as far as we talk about the environment, and yes, things that I use a lot, the words we don't know when we're discussing pathogenesis. I'm very honest because that's the reality. There are a lot of gaps that we don't know about the pathogenesis. And then we talk about the microbiome, the influence of the microbiome, but to what extent, we don't know, right? We know that it influences the development and the progression of the disease. We know about the tight relationship between inflammatory bowel disease and PSC, and how the more inflamed the colon is, the more we lose those tight junctions and we increase the passage of bacteria or bacterial products into the portal circulation and so forth. So we discussed that. But again, it's this combination of the heritable component and environment.
Yes.
And well, a lot of we don't know.
Well, I've got you, Cynthia. Let me just ask. So one person asked, I thought PSC was an autoimmune disease, but recently I've been hearing it's called an immune-mediated disease. How would you explain it to them? So we talk about, you've mentioned the different parts of it and the genes, but how about the immune system? What is happening? And
so my simplistic explanation to this, I'll let Gideon, the immunologist, address it. But my simplistic explanation is we tend to use autoimmune when we know what the antigen is and what the response is directed at. And when we don't know exactly what the trigger, what that antigen is, but there is this strong immune mediated component, all the autoantibodies, the association with autoimmune diseases, then we call it immune mediated. And the findings on histology, of course, that drive this thought. But it's the fact that we don't know exactly what the antigen is, right? Correct me, colleagues.
Yeah, it's all a play on words, isn't it? I mean, when we don't even know what a true autoimmune disease is. I mean, PBC, the other sort of sister disease of primary sclerosing cholangitis, where it's the small bile ducts where there's a particular autoantibody, you know, it's called an archetypal autoimmune disease because it has this autoantibody, which we therefore assume is, as Dr. Levy said, is the antigen, the trigger. It relates to the trigger. And in PSC, we don't know that. It's somewhat irrelevant, really, because inflammation is inflammation, and the inflammation is being triggered by your immune system, and the inflammation is persistent and chronic. And it's the continuous inflammation that leads to the damage. And, you know, whether it's autoimmune or autoinflammatory, I don't think is really going to change. It's just words for me. It's, you know, it's the fact that for whatever reason, the inflammation doesn't turn off very easily. And it's not steroid responsive. So it's a very unusual form of inflammation if it's autoimmune, because there really is no quick fix. So I'm with Dr. Levy. I mean, I try and move on from that because I think it doesn't help. I mean, I understand why people would like to sort of tackle that, because they want to know about other diseases which they consider autoimmune, like type 1 diabetes or thyroid disease and celiac disease, and whether they'll be more common if you've got PSC. And the truth is, they're not actually that much more common, and certainly compared to some of the other more, dare I say it, classical autoimmune diseases like celiac, you know, you don't see that same kind of clustering in PSC.
And how have we done, Gideon, with trying to suppress the immune system as a treatment for PSC?
Well, exactly. We've got nowhere, but that's because, you know, this inflammation, you know, when you think about disease, it's all about the kind of inflammation and where is the inflammation. And this disease, the inflammation is in the bile ducts. And the bile ducts are not passive tubes. The biliary epithelium, as we call them, you know, which make bile acids, you know, are not sitting there standalone. You know, the point is that, you know, when you damage a bile duct, you damage what bile ducts do, which is look after bile acids. And bile acids are incredibly complex chemicals with an incredible array of pro-inflammatory, pro-scarring, metabolic effects. And therefore, the disease is really about the inflammation and its location. So maybe if you had PSC of your fingertip, it would just look like inflammation and would go away with steroids. But you haven't. You've got PSC of your bile ducts. And when you damage the bile ducts, you upset the cart, you upset the bile acid homeostasis. And wow, I mean, you can comment on this as well, Dan. Bile acids are complex. They used to be, you know, understood by only a few people, and now they're only still understood by even only a few more people, because they are infinitely complex. It's as complex as the spinal cord or the microbiome, because there's thousands of different species and they all are chemical modulators.
Thank you. So Dennis, let me ask you another question that came up. Do you believe PSC is the same disease in a 10-year-old with inflammatory bowel disease as it is in a 70-year-old without IBD? Are we talking the same diseases here, guys?
That is a question I am often asked. I have even, we're not showing slides tonight, but I have even prepared one where there's a couple of kids on one side and adults on the other, and an arrow going across. You know, PSC, is it a different disease in adults and children? And I think I've evolved a little bit over the years. Early on, several years ago, as new features of pediatric PSC were sort of coming out. For instance, the significantly greater prevalence of overlap with autoimmune hepatitis in pediatric patients versus adult patients. The fact that small duct PSC is more prevalent in pediatric patients. And then fortunately for us, complications like cholangiocarcinoma and even dominant strictures are much less common in pediatric patients. And so, you know, it kind of, I had this model early on that maybe in pediatrics, there was maybe this really active immune mediated process going on because they're young, that's attacking the bile ducts, and maybe a little more vigorous, you know, focus on maybe intrahepatic bile ducts. And then as they get older and get fibrosis, and maybe as they get kind of burned out and autoimmune or immune-mediated activity wanes, there is progressive injury propagated by fibrosis and architectural distortion. And the bile duct cells aren't getting proper nutrients and that kind of thing. But now, as years have gone by, I'm pretty convinced they're pretty much the same disease. And what we're seeing in these differences are maybe the same probable pathogenic, you know, process of getting it going, but it's superimposed on developmental differences between kids and adults. So that's kind of where I am now. I've definitely changed my viewpoint over the years.
It's terrific, Dennis. Thank you. Cynthia or Gideon, you guys want to comment on that? Have any thoughts?
Well, I have some thoughts, which we've just about to publish something in the Journal of Hepatology where we sort of challenge, you know, this dichotomy between adults and children with PSC. And we talk about the ageless problem. And, you know, the way I think about it is, again, it's a problem of naming, isn't it? I have no doubt that there are some patients with PSC who start off looking very inflammatory. I just don't think it's autoimmune hepatitis. I think it's their response to their bile acids, and those bile acids cause a lot of inflammation. And that's not to say that steroids will not dampen that down, but they're not dampening it down in the same way as a classical patient with autoimmune hepatitis. And I don't know if everyone actually benefits from those steroids dampening it down, whether it really changes what happens. And I am totally intrigued when you think about what we've learned about bile acids, what bile acids do in the colon, and how bile acids change immunoregulation. So bile acids can make something look, dare I say it, autoimmune. They change immune function. So again, I think we've got this coalescence of worlds where, you know, really there isn't the world of immunology and the world of bile acids. They're actually all interacting all the time, and they're talking to each other. And what we have actually is not a very good way of describing what we see. I mean, that's really fundamentally our challenge, is that we describe what we see by looking down the microscope with, you know, just our eyes and some stains. We measure liver enzymes, and we aren't really measuring the right things, but that's coming, of course. And some of the work that PSC Partners is sort of involved in as fundraise for is to say, well, you know, instead of measuring things only in the buckets that we know exist, why don't we just measure everything and start to name the buckets and then see which buckets are more commonly relevant to our disease. And we'll discover buckets we didn't have names for before. And maybe that's where we'll get some new insights.
Yeah, terrific. Thank you, Gideon. Well, I'd like to switch gears here a little bit, guys, and switch over to talking about how we monitor our patients with PSC. So there were some excellent questions about, is there any way to predict how fast PSC progresses for the individual patient? And they made the excellent point as well, is this important if we can't actually stop or slow down PSC progression in the absence of effective therapies? And in addition, another person asked, are we getting any closer finding a dependable biomarker to measure PSC progression? Sort of Gideon made the transition kind of nicely for us. So what do you think? I mean, where do we stand? And what do you do with your patients in clinic? And how do you talk about progression? And frankly, what do you do with that information? How does it change how you might manage the individual patient you're following? Cynthia, you want to go first with that one? That's a lot to.
Yeah, that's a lot to tackle. And I'm sure we have guidelines to point us in the right directions, but our health systems are very different and allow us to do different things in different states or countries, right? I'll tell you how I do. So how do I assess prognosis? For the individual patient, frankly, I don't calculate Pratt score. I don't calculate Mayo risk score. Well, I'm not a pediatrician, so no scope score for me. Because I think that for the individual patient, that helps very little. It's rare. I can count, the times that a patient specifically asked me to look at their score because it's a more knowledgeable patient and we can go ahead and calculate. More knowledgeable, I mean, in the sense of knowing of the existence of these scores, right? So we can calculate and show them, but I don't know that they're that accurate to the individual, for the individual level. Then what tools do we have in clinical practice that can guide our judgment? So very easily, we can look at the liver biochemistries. And I do think Gideon has nice work on this. Just the level of alkaline phosphatase can really separate patients in buckets, those with the highest alkaline phosphatase, bilirubin. We know that those may be predictors that they may have more events or rougher progression. I look at liver stiffness. So it's widely available elastography, whether it's going to be transient elastography or if we have MRE available, but we all have one of these tools, or shear weight, we have one of these tools available. You can use cheap serologic markers and calculate FIB4 and APRI, and they have reasonable value as well. But I tend to use FibroScan, so transient elastography, because it's point of care and very easily. Understanding that, and I tell my patients this, don't get hung up on one value at this time. There are many things that affect the transient elastography, the liver stiffness, right? So whether it's congestion, food, alcohol, so the colon inflammation, I particularly think, I may not know exactly how, but I do think that when the IBD is very active, that alters my liver stiffness as well. I do think so, and they can confuse our judgment. So I don't use one value alone, and I combine all these features. So is my patient symptomatic or not? Do they have large duct versus small duct? And I think somebody asked a question there in the panel, in the chat, to explain large duct, small duct. So large duct is when there are visible changes in the bile ducts that we can examine on cholangiography, whether it is ERCP or MRCP, very easily spoken. And small duct is when the changes are only microscopic, only on biopsy. Okay, so that most patients, not more than 90%, will have the classic large duct form. And as was mentioned here, these patients all have very different phenotypes. So the small duct disease, it's a much more benign progression. We don't see cholangiocarcinoma in these people. They obviously won't have dominant strictures and obstructions unless they progress to large duct, which can occur in a minority of patients. So I use a combination of these variables: biochemistries, liver stiffness, symptom, no symptom. If they have large duct, is there evidence of a relevant stricture or not? Separate them into buckets, right? So if there is a yes for these patients with more of these features that indicate greater likelihood of progression or clinical events, I monitor them more frequently, maybe every 3 months, maybe every 6 months, very individualized. I tend to repeat liver stiffness once a year for these patients. And I tend to do MRI, if the insurance allows, MRI and CA19-9 once a year for cholangiocarcinoma surveillance. In the United States, most of us can do that if the patient has insurance. And if they're on the bucket with the low risk predictors, I may get a liver stiffness every couple of years. I may relax on that. And so I spoke a lot, but that's what I do now.
I think that's a wonderful summary.
Day-to-day basis.
Yes, and you're using that information, I suspect, Cynthia, to make a decision about whether your patient might require an ERCP.
Yes, so nowadays, we have learned, we know we don't need to do ERCP to diagnose PSC, right? The best of choice is MRI with MRCP. So that's the choice to diagnose the disease. So when do I do ERCP? If my patient has new symptoms that I want to evaluate. And I often do an MRI before doing the ERCP anyways, like a roadmap to help my endoscopist. Especially if they're like new itching and concern for a new stricture, I may do that. And of course, cholangitis, or worsening of the liver chemistries that is unexpected that may prompt further evaluation that will lead to an MRCP. But so I do that in response to something.
Wonderful. Thank you, Cynthia. What happens up in Canada, Gideon? Does that all sound reasonable to you?
Yeah, very similar. I mean, there are a few distinctions. I never do CA19-9. I don't think it contributes. I look at the patient's age. I look at their alkaline phosphatase. I look at their FibroScan, the elastography. And that, I think, to Cynthia's point, gives me a lot of information. I mean, I think, you know, that helps me a lot to work out which escalator they're on, and also whether they've moved from one slow escalator to a medium or fast escalator, which I think is what you're trying to do. What I find really hard, and I think I'll be interested to hear from Dennis, is doing that in the younger the patient, the harder I think that can be, particularly if you're being asked to future gaze even more. You know, and I do one other thing before I'd be interested to learn what happens in the pediatric world is I always anchor in my head that certainly in our program, the average age of transplant is 48. Okay. And I realized that the top end of that is slightly sort of cut off because it's hard to get a transplant in your 70s. But I use that piece of information to then work out where my patient is on that journey for that so-called classic patient. And that's, again, why largely, to Cynthia's point, those risk scores don't necessarily add much. Because if you've got a patient who's got, you know, an elevated alkaline phosphatase, who is, you know, obviously in their 30s, and, you know, maybe their spleen's already up a little bit, you kind of know that they will be average. And you can just subtract backwards. So that's sort of my loose approach to it.
Perfect. All right, Dennis, you're up. What do you?
Okay, well, in pediatrics, we do some of the same things, believe it or not. We do liver stiffness. We monitor that. We also, obviously, we don't follow alkaline phosphatase in children. We use the gamma GT, which is not fraught with problems with bone growth and other problems that alkaline phosphatase is in children. And it was, you know, it was really interesting, you know, when we saw the stratification of adult patients based on alkaline phosphatase in terms of prognosis, and we wondered, well, I wonder if that's going to be the case with gamma GT. And sure enough, when we were able to get enough data, particularly from the Pediatric PSC Consortium, Mark Deneau's project, we saw the same thing. If a patient during the first year after diagnosis in pediatrics maintained a low gamma GT, in this case, not 1.5, lower than 1.5 upper limit of normal, but less than 50 gamma GT value, they tend to do better than those that had the higher ones. But one thing about pediatric patients that I've noticed, and I think others have too, is, you know, their disease, particularly kind of early on, can really kind of wax and wane. They'll have prolonged periods where just nothing much changes, which is good because they're generally, and then they'll take a bump, something that their gamma GT will go up. Again, we fortunately don't have to worry that much at all about dominant strictures and even cholangitis. You know, we do see it occasionally, but not as much, I think, as the adults do. And for doing, for example, an MRCP, we don't routinely do one annually, even if the patient is doing well. But we're certainly prompted to, if there's any significant change that occurs. You know, we run in, we won't get into treatment, but the UDCA issue in pediatrics is—
We'll get into that, Dennis, don't worry.
Going on, I won't be quiet about that.
Oh, yes.
And of course, the risk score issue with the scope score, you know, it looks good on paper, and when they published it, it looked good. Here was something that easily obtainable laboratory values, and do they have small duct or large duct, and that's all you really know from imaging, and you put that into an algorithm, and the numbers looked pretty good in terms of looking at some prognostication. But invariably, when I try to do that kind of thing, and before that using some of the other scoring system, we're trying to prognosticate. Invariably, there'd be a patient, I would say, well, it looks like, you're likely to continue to do well and whatever. And then that'll be the patient who has a complication or has a sudden worsening. And then you feel bad for the patient, because you sort of, gave them this, what they perceived as good news, and then it didn't work out. And so I'm reticent. If a parent asks me to do a scope profile, I'll do it, but I'm very careful to, say, okay, this was based on data from a number of patients. And we're talking about, in the case of your child, one patient. And so if your child has a complication or other issue, maybe it's a certain percentage on the scope interpretation, but it's 100% for your child. And I guess, and the further along I go, I'm more sensitive to that. So yeah, the scores are interesting, and maybe for looking at in aggregate populations, how predictive these things are. But I do think they have somewhat limited value for the patients.
The individual, yeah, I couldn't agree.
Individual patients.
Let me ask you, because this question came up as well, I'm just curious. Did the pediatricians tend to do more biopsies in these patients? In the adult world, we don't tend to do them. But
yeah, at diagnosis, well, of course, in the adults, if there's a consideration of small duct PSC, then a biopsy is indicated. And in pediatrics, I think because there is an increased amount of small duct disease, and also overlap. I hate that term, overlap, but I'm not even sure what overlap is, but I won't get into that.
No, please.
But I think in pediatrics, we like to have a better handle on exactly what's going on with these patients. So, and I talk to my colleagues all the time, and biopsies have become, even though they are invasive, do carry some risk. As we've had our interventional radiology colleagues be doing more of them, they do a great job. Rarely ever have a complication. Most pediatric hepatologists will, at the time of diagnosis, go ahead and do a biopsy as part of the workup.
Interesting.
But not, not another one down the road. I mean, that's usually the only one that gets done. Usually we can monitor everything else non-invasively.
Basically. All right. Well, you brought it up, Dennis. Let's jump into it, guys. I want to talk some treatments. All right. So I want to hear each of your philosophies. Is there a role for the use of off-label therapies in the treatment of your patients with PSC? Who wants to go first?
All of the treatments are off-label. Let's make that clear, right?
Yeah, that has to be made clear. Don't you agree, Cynthia? That discussion has to be held with your patient.
Yeah. All right. I'll start with how I do. I know, people, this is a controversial topic, but it's challenging for us too as clinicians, because believe me, we want to start treatment. We want to do something that will alter your life, right? For the better. I am very pragmatic personally, and I like evidence-based medicine. So we try to do as much, to use as much data as we can when making these decisions. So both therapies that we're going to be talking about here are off-label, right? UDCA, and we'll talk about vancomycin. In the United States, we know that from the PSC partners, and we know that from, there was another survey in the UK also, it's about 50% of patients in Europe, 60% of the patients in the United States, roughly, using UDCA. my approach is to, okay, so I have a new diagnosis. I look at the alkaline phosphatase, right? So if it's minimally elevated and one of those good prognosis type of patients, I may not start anything. We'll have this conversation saying that there is no FDA approved treatment. If the alk phos is elevated, I always try to explain the importance of the clinical trials to my patients. And I'm lucky to be able to conduct a lot of these trials in my center. So, and I see a couple of my hardcore patients participating in the conference today. So it's important because that's how we're going to find out a treatment that is proven to be effective in changing outcomes in this disease. Now, if the patient doesn't want to or doesn't qualify for a clinical trial, then I do discuss UDCA first because I think we have far more robust data in terms of safety. I know Gideon doesn't use URSO, so that will be a good discussion. But I do for those patients with elevated alk phos who do not want to or cannot participate in a study. And I give it a trial for 6 to 12 months and see how the numbers do and how the patients feel on the treatment. And then we may or may not discontinue therapy depending on how that goes. And the dose I use is between 15 and 20 milligrams per kilo per day, roughly. And I think that's the dose that is endorsed by both ASLD and EASL guidelines if we are to use UDCA. So my take on the vancomycin is not that I don't want to prescribe vancomycin. I think we have insufficient amount of data in adults with PSC, data coming from clinical trials. Why are those important? Because it's more controlled. We can see, we can collect adverse events, we can collect all the safety and efficacy data in a systematic way and minimize bias in those studies. So when you think about clinical trials for adults taking vancomycin, we'll have 30 patients who have participated in a clinical trial, something around that ballpark. So I don't feel comfortable. I don't think we have enough data. The pediatric population, we can hear from Dr. Black. Now, not to say that I haven't done it. I have used it in a couple of patients who had also more active inflammatory bowel disease. It did help one perspective, didn't help the other. So that's it. I'm not ready to use vancomycin. Patients and advocates know my position just because we don't have enough data from clinical trial. I think it's insufficient. That's all.
That's all right, Cynthia. And can I ask you, when you think about URSO, is there an alk phos level you're looking for that justifies initiating therapy? And what do you use as your justification to continue therapy?
Roughly above 1.5 times the upper limit of normal, more or less, or 200 range. Why? Because that we can say, right? There are several studies from the US and abroad showing that patients with lower levels of alkaline phosphatase have better prognosis, right? Either spontaneously or as a result of URSO. We also know, I know we can counter that by saying, okay, in the high dose URSO, there was improvement in alk phos, but patients had poorer prognosis. But there were other variables there also to be accounted for, different species of bioacids that accumulated that could have been more hepatotoxic, cytotoxic, that could have accounted for that. But in general, the patients who have lower levels of alkaline phosphatase, either who normalize or who drop below 1.5 times, depending on the study that you look at, have lower rate of events, lower progression to cirrhosis, lower cholangiocarcinoma. Limited number of studies, but that's all we have. So outside of a clinical trial, which is my first option, then that's what I go for.
All right, well, let's go to Dennis, and I'm going to finish with Gideon at the end. Dennis, why don't you tell us, in the pediatric world, are you an oral vancomycin person?
Well, yeah, I'll talk about that before I say a word or two about URSO.
Sure, or either way.
Well, you know, the vancomycin issue in pediatrics is at a state right now. I really don't know how to sort it out, because, you know, you talk about the difficulty in doing randomized controlled trials in adults. You take that into pediatrics, it's just tremendously more difficult. And then the more patients who are on off-label vancomycin, your pool of patients to have for those RCTs, those randomized controlled trials, is shrinking. So, you know, at least in pediatrics, I don't know if we'll ever be able to do a randomized controlled trial. And so that's a little sobering, but that's because I think that's really is what's needed. I think, you know, that there are some data out there showing that vancomycin, it looks promising if we were to know how to use it and who to use it in. But again, we don't really know that. And of course, in children, which, you know, for clinical research are considered vulnerable population, these are vulnerable patients where we're even more careful about doing things, you know, off-label, which is often just not labeled for pediatrics, much less for that indication. You know, we do consider things like long-term effects of vancomycin, you know, on the microbiome or other long-term use, because we don't know how long to use it. We don't know for sure who is likely to respond the best, and if we were going to use it, you know, to be at least selective about it. You know, I don't know. I mean, so I guess we're at the point, do we try to come up with some guidance or whatever on maybe patients to perhaps use it on? But in pediatrics, at least, knowing we'll probably never have adequate data to make that determination. And I'll say I have used vancomycin in 3 patients. And again, these were patients with somewhat more severe disease and active IBD. All 3 of them got better, both their IBD and their liver disease. But that's 3, you know, and that doesn't cut it. So I think maybe one thing it might help, the numbers game, is being able to do trials where you have a defined cohort that you can do, you know, case control and matching in lieu of a placebo group. I think that shows promise, and I know industry is doing that more and more for drug trials for rare diseases. But yeah, vancomycin, I'll just be honest, you know, I think it has shown some benefit, but I wish we knew more about it. And in particularly in children, I wish we knew more about it. And
Urso, do you want to comment quickly on that?
Well, and I don't know for sure what we're doing with Urso either. You know, and just to give you an example of that, you know, a lot of pediatric patients, you know, have come to me on Urso. You know, for a while there, back in the day, Urso was the tonic for the liver. You know, pretty much anything going on, you know, give a little touch of Urso, and you know, things will get better. And of course, you know, by improvements in the biochemistries, but yet still not affecting in game of the disease. That really deceived a lot of us, you know, for that. But I was humbled by a study that we did a little while back, where we had all these kids on Urso who come to us, and parents didn't want to stop it. Even when we talked about, you know, the potential for, we talked about the adult, you know, NIH study and so forth. They said, well, his liver numbers have come down to normal. How can that be bad? And we're not sure we want to stop it and whatever. So we did this prospective trial where we took the pediatric patients on Urso, and then in a stepwise fashion, we withdrew it. Took them off of it for several weeks and followed them obviously very closely, and then put them back on it. And interestingly enough, we could stratify those patients in terms of what happened into 3 groups. About a third of them, when they came off, and they all had gamma GT below 50 when they came in. A third of them stayed below 50, you know, did fine. Another third had a flare where their ALT and gamma GT went up, and then we put them back on it, and it came right back down again. And then there was this other third kind of in the middle where it went up a little bit above normal, but didn't get the threshold for what we called a major flare in the study. So there may be patients out there who can benefit from it, but the only thing we could find about that group who had the major flare when they came off were a couple of things. They had a shorter time from the time of diagnosis to going on the study. And when we looked at some cytokine levels during the study, pre-study and everything, those who at entry into the study had higher levels of IL-8 and TNF-alpha, that kind of predicted that they would have this flare. But, still don't know what that means, and I don't know how to use that, clinically. But now, one thing I will mention from the PSC, pediatric PSC study, they were able to, when they were looking at the prognostic or which level of gamma GT, the ones who were lower did better. If they had lowered their gamma GT by being on URSO, that also put them into that better prognosis category. So what it was doing there, I don't know, but that shows a little bit more, I think, of something going on beneficial than maybe the adult studies have. So I think the question is the issue, the whole issue of URSO is kind of still out there. We do know a lot about its safety profile, I think, and using it, but we still lack any precision in knowing who to give it to and what we're really doing with it. And I didn't mean to go on for so long.
No, it was wonderful. Thank you. And Gideon, what's your philosophy?
Well, I guess slightly different to the others. I don't really worry about whether a drug is on label or off label. It's more about whether I can get someone will pay for it. I do not feel under any obligation to write a prescription at any time when I see a patient. It never crosses my mind whether or not it's the first time I've met them or I've seen them 100 times. And I never think, oh, I must make a therapeutic decision based on a certain criteria. And what I try and do is individualize the patient in front of me and give them the benefit of the doubt that this is a particularly difficult disease where the natural history, treated or untreated, however you want to describe natural history, has some significant obstacles if you're a patient because of the high rate of transplantation, which is never a certainty in life. So do I use URSO? Sometimes. Do I use Vanco? Sometimes. Do I use bezafibrate? Sometimes. Do I use Cipro? Sometimes. And how I sometimes make that choice, I'm afraid, is the old-fashioned, based on what I sense is right for that patient at that time, based on the problems they face. So I'll give you some examples. If I see someone who has got intrahepatic bile duct stones, it is likely I will give them ursodeoxycholic acid, because I know, regardless of what URSO does from a long-term natural history, it is a choleretic agent, and it is better that they have less stones. And ERCP is not always going to be the answer, and they lose very little. If I see someone who comes to me and says, I think Vanco is the answer, and cost is not relevant, and they've got active IBD, and I've done this, then am I happy to start vancomycin? Yes. But I tell them, a bit like Dennis and Cynthia, I've got patients who've been on vancomycin where it helped, and patients where on vancomycin where it very clearly made absolutely no difference whatsoever. And I will tell them the vancomycin will almost certainly help their colitis. I think that's pretty clear. And that's good. Yeah. And we've got patients where the Vanco is better than a biologic. But whether that is actually, how that is interacting with their PSC, I'm not sure. But I won't stand in anyone's way. But I will explain to them that I'm not the bank of paying for medicines, unfortunately, and that's a big challenge. But so I will use it, and then increasingly, am I occasionally using bezafibrate? So the answer is yes. I have access to that in in Canada. I wouldn't use fenofibrate for a variety of reasons, Cynthia, but do I consider it for treating itch? Yes, not as my first line necessarily, but I consider it. And have I used the combination of bezafibrate and vancomycin post-transplant? Yes, I have. Where the access to trials does not exist. So this is caveated by the fact that I will put my hand up for my unit for every single clinical trial going for PSC, nearly without fail. And between myself and my colleagues, we will volunteer, but there are different trials at different times. So sometimes there isn't a trial. So I don't warehouse patients on the hope that there's a study coming next week. I tell them what's available today, or in the very, very near future. So that's my kind of old school physician approach. And maybe that's why I enjoy the job that I do, because I'm, perhaps I'm a little bit stubborn. I won't fall into the trap of having an answer or a solution for every single problem. I'd rather work it out live as I see the patient.
Yes. And I'm just curious, Gideon, because you made the point earlier when you were talking about your different escalator speeds. Is that driving your decision? You got somebody on the fast escalator, you may be inclined to push therapy.
No, because if you're on the fast escalator, I guarantee you URSO does nothing. I mean, so if URSO is doing something, it's only doing something in the patients who've got a very, very long natural history, who are probably closer to a small bile duct phenotype than to a large bile duct phenotype, because what URSO is actually doing is mopping up bile acid toxicity close to the small biliary epithelium. It's doing absolutely nothing to the large bile ducts, absolutely nothing. It's inconceivable that ursodeoxycholic acid could change stricturing stenosing disease like PSC. It's inconceivable through its mechanism of action. But we talked about how in this disease, what you've really got is a luminal disease, so a tubular disease where you've got inflammation and then you've got stenosis. So when that happens, the pressure within that tube goes up. Okay, so intraluminal pressure rises. And what that means is there's a distal effect. So pushing back into the liver, there's a pressure rise and there's a pressure gradient, which means that there is damage going on at the point of the stenosis, but there's secondary damage from the rise in pressure. And then what ursodeoxycholic acid, in my opinion, is doing is mopping up some of that bile acid injury higher up around the small bile ducts. And that's the reason why it's so effective in PBC, because you've only got small bile duct disease and you've got tons of them. And for a number of patients, if you mop up the bile acids, it's enough. Not by no means enough, not everyone in PBC. So in my mind, it's the exact opposite, Dan. If you're on the fast escalator, then it's highly improbable that those treatments will help. The only difference is, conceptually, and I think Dennis hit it, on the spot. Actually, what I don't know is plasticity. And by plasticity, when you have a disease which is chronic, really the outcome of the disease is how strong is the insult versus how good is the repair. And we don't know how to measure how good you are at repairing. And it may be, as Dennis alluded to, and this is probably across all patients, but it's particularly noticeable in kids, that some people earlier on are better at repairing. And that may well be the time when some interventions could be better. Mm-hmm. And the last point is, we talked about trials, but actually there's an absolute flaw in that approach. Because if you have a disease where you don't know the cause, it may well be that 2 in 100 patients with PSC have a cause of PSC that is exquisitively responsive to vancomycin. Okay, because actually they don't have PSC, they have PSC version 2 out of 100. You will never pick up those 2 out of 100 people in a randomized controlled clinical trial. It is not designed to pick out rare phenotypes. It's impossible because the design is not in favor.
Yeah, I would love to come back to that, Gideon. We'll talk about trials in a bit, but absolutely right. Well, let me ask you. I asked Cynthia this. So what is your endpoint? You started therapy. You said, all right, Vanco is what we're going to do. Bezafibrate is what we're going to do. How do you monitor that response? And do you ever stop therapy again? Are you monitoring response and looking for a response?
Yeah, so I think that's a great question. I think it depends on why I'm giving the treatment. If I'm treating itch, then itch is the response. again, I think it would depend on the relativity. So, Urso's tried and tested, and we are absolutely confident at 15 to 20 milligrams per kilogram that it's safe. In which case, if you do use it, then I would probably agree with Cynthia. I'd use it the same way as she does. That if I give it, there's got to be some improvement in alkaline phosphatase. I think I'm a little bit more stringent with vancomycin because there is, more to learn about vancomycin. So I think if I do use vancomycin for patients, I say to them up front, I think you will stop it for sure unless there's something more objective that really tells us, and that's a really significant improvement in alkaline phosphatase, not just a small improvement. So, again, I individualize, but I think, generally, if I make a therapeutic decision, then yes, it's along the lines of Cynthia's approach, which is, having agreed that we're going to do something, because I first of all tell the patient it's okay to do nothing. There's absolutely no problem here if you choose to do nothing. Okay, that is statistically, based on what we know, the same as doing something. But if you wish to do something, because of then the added risks and or cost, then I agree we should say, what is our sort of 3-month, 12-month sign that this is a drug that we continue.
Perfect. Let me ask the whole group too. Do you believe that through our manipulation of the microbiome, is that of benefit in therapy? So let's say diet. Are we talking probiotics? Someone asked about prebiotics, fecal transplants, oral vancomycin. Where is the level of, what are we doing with these things? And is there something to be done there? And can manipulation of the microbiome perhaps be part of the answer?
Well, it seems to me that, there actually has been some limited study of FMT, microbiome transplant with PSC. And as I recall, the results were not overwhelming. Again, it was a small number and maybe not optimally done or whatever, but, it probably plays a role, because we're talking about, the organisms that may get through the epithelial barrier and, all these theories of, how they contribute. But I think we still need to learn a lot more about how that works. And when you give an antibiotic, you are altering the microbiome. And in the case of pediatric studies, we know that if you give a child an antibiotic for an ear infection, when they're 4 years old, you will permanently alter their microbiome profile.
Wow.
So we need to give it some thought, proceed carefully, but I think we're a long way from knowing what to do. And that includes even using probiotics and prebiotics.
What advice do you guys give? If someone asks you, can I use probiotics? Have any concerns?
I tell the parents it's okay, but not to be, too optimistic. It'll help, but I don't see.
Couldn't hurt. Is that what you're saying, Dennis? Yeah. What do you think, Cynthia or Gideon? Is there ever a time that probiotics can be of negative effects?
I don't imagine a negative effect for probiotic or prebiotic at this point. We have a lot more to learn. But we have learned a few things about the microbiome in PSC, and we know there is decreased diversity, right? So when asking about the FMT, the fecal microbiome transplant study, I see that only as a proof of concept. That was just the beginning, and I believe we will make progress in that. Even though there were only 10 patients, the trial was not really designed to look at impact on the liver disease. The patient population was quite heterogeneous, some with, some without IBD, some on, some not on Urso, but they did observe that with the FMT, there was improvement in diversity, right? That was actually what they were looking for. So now we have to learn, okay, how often do we need to do that? What's the interval between doses? Is this gonna last or not? And does this correlate with a better outcome in the end or not? So we're in the beginnings, to try and understand. But I do see a role for the manipulation of the microbiome, whether with FMT or antibiotics. We will learn, right? And there are other studies with the phages. There are particular bacteria that are overrepresented in the biome in patients with PSC, and they may have a pathogenic role. We didn't discuss that. So as we learn more about specific bacteria that may have a role, we can target therapies. And so that is far in the future, but I do see a role for that. Somebody asked, you mentioned about diet.
Mm-hmm.
There haven't been many studies for diet in PSC, and those are really hard to conduct because you have to make everything, you standardize everything else, not only the diet, which is already difficult, and everything else, the antibiotics included, and every medication. Christoph Schramm just published a paper on the gluten-free diet, right? It didn't help with the biochemistries. It did improve a little bit, I think, on the diversity in the biome, I think, changed, but no improvement in symptoms or liver chemistries yet with that approach. So we have to do some work.
Yeah. Any perspective on supplements? And curcumin was one that somebody asked a specific question on the chat, on the Q&A. What do you tell your patients?
I don't think there is good evidence for that, and I'm always so cautious with supplements because we know curcumin in high dose can be hepatotoxic, right? There are reports, so I'm not there yet.
I do not recommend when parents come to me with various dietary supplements.
Yeah.
I recommend across the board not to use them, and not only in that it might be a particular supplement that may, have a harmful effect, as an adverse effect of the supplement, because I really have lost confidence that we really know what is in those supplements. In terms of, I think somebody not long ago bought a bunch of supplements and they actually tested what was in them.
Yeah.
And there was a high
NIH
percentage that didn't even have any of the supplement in there that was supposed to be in it. And so because they're not regulated by the FDA, I do, and particularly in children who represent a vulnerable population to begin with, I just kind of discourage them. My practice now is to discourage it across the board.
Gideon, how about you?
Pretty laid back. But I take Dennis's point really more about vulnerability and how you're trying to protect. So I think I'd like to empower patients to feel that they are, making decisions that are, individualized to themselves, not just around things that I can prescribe. So I sort of take an open-minded approach, but explain exactly what Dennis just said in terms of risks, the risks that you're really taking nothing but spending a lot of money. And to what Cynthia says, that occasionally there may be, some detrimental side effects. And I think hopefully as you sort of look after these patients, and one of the sort of great pleasures of doing PSC clinic is you look after patients for a long time, you get to know the patients and you're guiding them not about on a single day, but you're guiding them over years and years and years. And so, with that kind of approach, I explain my cynicism, but I don't stand in the way of someone who makes a good argument as to why they'd like to try X or Y. I would stand in the way of someone who was doing something which to me was extreme, which was moving beyond the kind of, well, I think a gluten-free diet is good for the immune system, or I can make a case that, it's better to have a different variety of bugs in my colon because there's some logic that, over time, the bug species has moved in the wrong direction. So if something to Dennis's point is going to clearly be extreme and outside of that sort of, broad approach, then the patient will certainly hear quite clearly from me what I think. But I'm a big believer in empowering the patient to take part. I've seen huge benefits from patients taking part in clinical trials.
Yes.
Regardless of the clinical trial or the result.
Mm-hmm.
The mere fact of taking part in a clinical trial and making that decision that you're going to try something and being in charge of that decision, I've seen to be a very positive thing. So I kind of practice within that sort of framework of all the decisions I make.
Perfect.
Of course, let me make just one point around that. Don't get me wrong, like we work with the patients, right? If my patient says, this is what I want to do, as long as I know for sure it's not a harmful thing, we'll work with the patients. But I absolutely tell all of them exactly this study that Dennis mentioned, this NIH study that they took 100 pills of milk thistle and they looked at the concentration of each pill in the same bottle, and they each capsule had a different concentration and different concoction as the mixer. So, that tells us we don't know what we're taking. It's not just the patient doesn't know. We don't know what's in there. This is not regulated by the FDA. And there are plenty of reported and unreported cases of hepatic toxicity. So I'm usually more in the discouraging side, but obviously if the patient wants to try it, Gideon, I'm not going to kick them out of my practice. No,
They would never leave your
always
practice.
Work together, right?
What patients, Cynthia, would leave Miami?
Also, but
Yeah. They would never leave Miami to come to Toronto. You don't need to worry. The weather is diametrically opposite, and they love you to bits, so you don't need to worry.
Oh, I just sent you somebody. Okay, we'll talk about that later.
Let's switch, guys, and I'd like to finish up with some talk about some of the clinical trials. And I'd love to hear from each of you, all being experts, is what are the challenges we face in actually performing high quality clinical trials in PSC, and they're significant. So let's hear, how do we make these work? Gideon, you want to go first?
Yeah, well, I mean, that's another great question. If you want the actual off-the-wall answer, I think if you want to crack PSC, we need to behave like oncology hematologists behaved 25 years ago. I think that there's a little bit too much autonomy. And if you really wanted to crack PSC, you would recruit every patient to the clinical trial, and they would all be in a clinical trial which continue to move along and change continuously. So it's what's known as an adaptive study, where you're assessing multiple treatments continuously, and you're dropping treatments that don't work, and you're moving patients to treatments that do work, and then you can combine therapies. And if you look at why leukemia outcomes really improved, one of the things was the participation in clinical trials, nearly universally. There was whatever you were doing, you were probably in a trial, whether it was just observational or an intervention. And I think if you really want to crack PSC, that's the kind of attitude that we need to, as a group of clinicians and patients and patient advocates, be trying to get to, because I think that will accelerate the answer. Because at the moment, the minority of patients take part in clinical trials. And that's why people then are frustrated how long it takes to get an answer. Because if we just to take some of the questions around URSO or VANCO, there are enough patients and enough events that the world could have answered this already. But, we haven't, because of how we practice. And then, as to what a trial looks like, I think it depends on the drug, the target, whether it's symptoms, whether it's disease modification. I think they have to be individualized. But we really, really, really need everyone to be behind studies, because studies are expensive. They are risky, mainly financially. They are not very risky to patients. Let me be clear. Trials are probably the safest thing you'll ever do, if anyone's ever looked at the amount of paperwork that goes into a study. It's a lot safer than your routine standard of care. Okay, but it's someone's financial risk, and we want to encourage them to take that gamble for our disease. And we'll only do that if we recruit. So that's my high level.
Well, let me give you a question, Gideon. As you know, the hope is a lot of the antifibrotics might be the answer in PSC. Lots of studies coming out. what are the endpoints that would justify that? And how do we avoid needing to do 2-year, 3-year, 4-year trials? You know, how do we get?
I'm not sure you need to avoid doing a 2 or 3-year study, because remember, the worst thing that we could see happen in the field of PSC is for a drug that's not very good to get licensed, okay? And then for everyone to be on that drug, and for that to slow down the drug that really does work, because it becomes a heterogeneity factor. Everyone's on it, and you start to sort of see what we've done with Urso.
Yes.
So there's nothing wrong with a 2 or 3-year study if it means that you get a drug that really changes the history of PSC for decades and decades. Really, you know, the truth is we need to get better biomarkers in terms of measures of scarring, which are going to be a combination of blood tests and elastography and imaging. And to do that, you know, I'll put a plug in, you know, we need to get behind PSC partners and do things like their prospective WIN cohort. And we need to work collaboratively between PSC partners and industry and charity to fund it so that it captures not just what I do routinely, but just gives me enough money to capture a blood test and put it in the freezer, okay? And have that blood test ready when someone says, I've got a really good idea. You know, can we get 5,000 samples and run those samples, you know, because I've got the idea, I just don't have the samples. But remember, what stops us doing that at the moment is basically, you know, it costs a lot of money. You'll know this, Dan. It's something as simple as even storing a blood sample in your freezer is not standard of care. But that's where we need that accelerator. So hopefully the WIN project will be one of the accelerators, at least certainly in North America. You know, so, you know, I think fibrosis markers are coming and they'll be very powerful. But actually, for a really good drug, liver biopsy will work. You know, if the drug's effective, I think you will be able to design a study based on liver biopsy.
Mm-hmm. Cynthia, what do you think?
Yeah, those are all great points. I agree 100%. We need clinical trials, and that's the only way to find an effective therapy. Despite all the heterogeneity in PSC, we have to work together. That's where our minds come together, designing studies that try to control as much as possible for this heterogeneity in order to at least complete a study with feasible endpoints. Also agree, wind in my heart is like one of the answers for, you asked what's the challenge with clinical trials? Why are we not completing the clinical trials? Well, number one, if we don't know for sure the pathogenesis, so we go back to the beginning, it's hard to find the right target. So our therapies to begin with are not targeting exactly what triggers PSC because we don't know what that is. It's already targeting some end result to some extent, right? That's one of the challenges. So we use surrogates as our endpoints. Placebo. Patients don't want to be on placebo. If I were a patient, I wouldn't want to be on a placebo if I had a good option, right? So that delays enrollment. The placebo is necessary, like for safety and to help us have a comparator and understand, is our drug really doing something, right? Only if we have a placebo. What's the alternative? Wind, hopefully. That's what we are preparing for. So if we have a cohort of patients, a group of patients that we can follow long term and collect their information, not only the labs, the routine standard of care labs, but as Gideon is mentioning, we need to be able to do biospecimen storage so that we can check for all these biomarkers as we learn about them. And we can use this cohort as the comparator arm to active drugs studied in trials. We can minimize the role of the placebo, right? Ideally. So that's what we're working for. I think that's one of the challenges, is to not have a placebo. The liver biopsy, of course, it would be great to not have to do it, but I haven't seen in previous studies, our community of patients with PSC, you guys are great. It hasn't been an issue for the studies that we have had so far. When there is a good rationale for the study, then we can convince ourselves first. And if I am happy with that, then I can convince and explain to the patients. And we don't see a problem with enrollment in that. From that standpoint, I really think it's the placebo. And in terms of designing of the studies, a lot of our sponsors are understanding and are partnering with us, scientists, with PSC partners, and understanding that patients need something in return. So all those open label extensions that we have at the end of randomized controlled trials I see them, of course, we're collecting information, but it's a reward also, because even if you go on a placebo for a shorter period of time, then for sure you're going to get the active drug if it's proving to be efficacious or highly suspicious. We think that it's efficacious, then it's going to go into this open label and everybody gets the chance to really get an active drug. I agree, patients, my God, you don't know, when we design clinical trials, there are so many levels of safety nets that we put together to prevent as much as humanly possible complications for our patients. So this is in place. Gideon said something that I was going to add to. But anyways, yeah, that the patients do better when they're participating in clinical trials. One, because yes, you're empowered and you're doing something that you know has the potential to be very helpful for yourself or for a family member, right? But also because remember, when you're coming every 2 or 3 months to our offices, we're doing physical exams, we're doing labs, so we're monitoring you very closely, and should anything happen, even as part of your natural history, we're more likely to pick it up early and treat it. So outcomes tend to be better for patients who are participating in clinical trials in that regard. That's it from my 2 cents.
Dennis, can I give you 30 seconds for the pediatric perspective?
I agree with everything that's been said. PSC is particularly, out of all the diseases I deal with, it is the most frustrating and difficult to deal with in terms of coming up with clinical trials, recruiting patients. I mean, that withdrawal URSO study that we did, it took us about 5 years to get 27 patients to agree to come off ursodeoxycholic acid. So I think the WIN project, as I see it, is going to be our moon mission.
Yes.
For getting at, understanding PSC better, learning what the targets are to aim for, and being able to do some trials, and maybe without a placebo group, using a predefined cohort. And we're going to have to be innovative as we go forward with this. And everybody's going to have to get on board. Too few patients. Pediatric PSC is 1/5 the incidence of adults. So you see what kind of boat we're in.
Yeah. Well, thank you, Dennis. Oh my gosh, that was absolutely terrific. I want to thank all 3 of our panelists, Dr. Black, Dr. Hirschfield, and Dr. Levy, for participating this evening. We so appreciate their willingness to give their time and to share their expertise with us tonight. And this was actually a great deal of fun for me, as I knew it would be, and hopefully informative for all of you. And I'm really sorry if we weren't able to get to your specific questions, but there will be opportunities for the panelists to answer some of those briefly. And I hope that this will be the first of many fireside chats hosted by PSC partners. So with that, I will now hand it back to Ricky for some closing remarks.
Great. Thank you. Yes, this was really amazing. When we decided to try this fireside chat, we had no idea how it was going to work out. And I am just overwhelmed with how amazing and wonderful it was. Thank you, Doctors Levy, Hirschfield, Black, and Pratt, for your informative and honest comments to all these questions on a wide variety of topics. I just loved hearing all the different philosophies and opinions. Our disease is so complicated, and we know there are so many unknowns. It was really helpful to me as a patient to hear all the different theories and the rationales for them. And I really appreciate all of your honesty. And I also just want to say that we are just so lucky to have providers like all of you helping us and volunteering all your time and your passion to help us. We greatly appreciate it. I hope you all understand that. And so with that, I would like to just quickly go through our future events. Please visit pscpartners.org, join our patient registry, our mentor program, listen to our monthly podcasts, sign up for a mailing list, and follow us on social media. For Canadians, please also visit pscpartners.ca, sign up for their mailing list and follow them on social media. Webinars I mentioned at the beginning, the annual conference brainstorming webinar. I know we originally had scheduled it for March 8th, but we're still negotiating. And as soon as that's set, we will send out the new date. Please think of joining our Embracing Diversity and PSC webinar. It will be really an interesting one. Zoom rooms, all at 6 to 7 p.m. Mountain Time. March 23rd, it is adult patients with PSC and post-transplant patients 18 and over. Living with loss and caring on the spirit will be March 29th, and caregivers, spouses, and parents of patients with PSC and post-transplant will be April 19th. And then to end, please take a few minutes to complete the exit survey that's in your inbox, or you can click on the QR code here. And also, if you are interested in hearing the Fulton Brothers song that they recorded for PSC Partners in memory of their dad, please stay on now. We're going to view the beautiful and heartwarming tribute video that they made for us. And again, thank you to all of our community and corporate sponsors. Thank you, everyone, for joining tonight. It was terrific. Thank you.
One, two.